Thank you, Dr. Dorff, for an exceptional discussion about clinical trials. I'm going to take us in the next 20 minutes to really do a deeper dive on this topic of how do we really improve our accrual. And hopefully we can have some strategies by the end of this discussion that you can implement in your own practice. I have the pleasure of being a medical oncologist in Detroit, Michigan at the Karmanos Cancer Institute. And I've been there for 17 years, and it's honestly a true joy for me to serve my community. We do a lot of clinical trials in our institution, and every day I am faced with this reality. And the reality is that many of the adults with cancer do not enroll in clinical trials. Now, I'm not talking about genitourinary cancers. I'm just talking about all cancer-related trials. So when you're looking at a 3 to 5% of adults really enrolling, that's a bit of a smack in the face. We know we need to do better, but it's just so difficult. And the question is why? I think Dr. Dorff sort of investigated that idea of why, but in where I practice, I recognize some of the challenges that are perhaps more on a local basis. So I'm encouraging all of you to think about what are some strategies you can implement in your own practice to improve your numbers. We know that the majority of patients who do enroll are mostly white, and that there are really minimal representation of minority, elderly, rural, and underserved population. But all of these will be talked about in just a little bit. The one question I always get from patients is, are there actual trials for my cancer doctor? And that's if they ask. But if they do, there are trials that are available. So I just did a brief search on clinicaltrials.gov a few days ago, and you can see just by typing in breast cancer, lung cancer, prostate, renal, bladder, these are the numbers that pop up. So you're not looking at 10 or 20 trials that are available, but there are literally thousands of studies that can be considered. In the state of Michigan, where I practice, it's important to know that the Michigan Cancer Consortium, which is a statewide organization, is committed to increasing these numbers. But if you even look at one of the pillars, which is, yep, we really want to increase these numbers, the percentage is from 4.4 to 4.8%. You could argue that's minimally changing the standard, but I argue back and say any change is welcome. And in the state of Michigan, this is something that we really take pride in to try it in any capacity to increase these numbers. Now, many of us in practice know the barriers to accrual. We experience it every day. Patients are worried about the risks. They're worried about having a placebo as part of their treatment. They're worried about who's going to get information regarding their medical records or their medical history. Will insurance cover it? Maybe the trial that I want is not available. Maybe I'm not eligible. Maybe my primary care physician or my spiritual leader doesn't endorse me undergoing a study. There's a lot of mistrust and fear of medical research. I think that still exists today in 2020, perhaps heightened with the COVID pandemic. Don't know. In my own practice, it certainly is a topic that hasn't gotten away in all the years I've been here. And it's certainly a topic that continues to be of discussion. We also worry and mistrust the pharmaceutical sponsor. A lot of that, again, is just from stories being handed down from family member to neighbor to special groups. So it's something where we have to be aware of the conversation. We also recognize that consent forms are just really not just hard to write, but really hard to read. We want them to be an 8th grade level, but sometimes they're more complicated. You mentioned the word immunotherapy and you're already at college level. In our area, we have a lot of grandparents that serve as parents. So the time commitment to be able to go on a trial is limited because they have to be there for their grandkids. Some have transportation issues. Maybe they just have a lot of medical comorbidities that doesn't allow for them to go and be eligible for a study. But I think when you really look in your own practice, in your own community, in your own hospital, you have to recognize that there are other local barriers that might be there that perhaps you weren't really mindful of. So I think part of the topic today is to be aware of your surroundings of where you practice and say, gosh, maybe there are additional barriers. So in Detroit, all of those issues that I just mentioned are there, but we also have a functional illiteracy rate in Detroit of 47%. That means major challenges when you're trying to provide a consent form for patients to read. We know the functional illiteracy rate in the state of Michigan is considerably lower. And also our unemployment rate is at 10.3%. And these are pre-COVID numbers. So I don't know what we will be at post-COVID or if there is a post-COVID number, but certainly these numbers are not going to improve with the current situation. So we recognize that, we're aware of the limitations, and we incorporate some of those challenges into our day-to-day. So to think about potential strategies to reduce some of these barriers, we absolutely try to engage the community. We have an entire office of health equity within our cancer center to really look at how do you get the messaging across. There are centers around the country that have the luxury of having patient navigators. I envy all of you who do have them, because I think they are a tremendous resource and really something that would benefit patients. I think recognizing that whatever we do to reduce these barriers requires a team is also something that has become much more commonplace in many institutions and also in many care facilities. And we know that it requires lots of folks like social workers and leaders and other cancer-related physicians to help with endorsing this idea that clinical studies are a way to advance the field. But if you really think about what can you as the provider do, day to day, we can easily encourage our patients to ask questions. You know, when I say this, you say, well, do you have any questions for me? I think the question is, what's the question? So if you visit cancer.gov /clinical trials, there's a list of questions that you can perhaps leave in the exam room or in your waiting room, or email it or put it as part of your website to say, these are some of the questions that perhaps your patients should ask you during the visit. You can also encourage that patient to bring a family member or a friend. Obviously, we're in times of COVID, so what can you do? They can be on the phone. They can be present on the phone, either just regular telephone or, you know, doing a video assessment. But all in all, you can be very patient with the process, which is really hard to do when you're in an active, very busy practice. But you can encourage them to take their time. And that might mean that they take the consent form home and discuss it and give them a few weeks. It might mean a phone call from your research nurse to see how they're doing. And you really understand that there's no pressure to enroll. This is a conversation. This is a collaboration. This is no pressure. You also can be the advocate. And I think this cartoon sort of highlights many of our frustrations when you have clinical trials and you're very eager to enroll and the patient is eager to enroll, but they don't qualify. And you've done all this work to get their eligibility and they're down to one last point of 0.1 off of the actual accepted number, and you get frustrated. So when I say be the advocate, I would say use your voice to say that I would love to be able to put this patient on, but perhaps we can relax some of the rules on these studies so that patients who really reflect the real world can enroll. Because guess what? Once they do get FDA approved, these are going to be prescribed for real world patients. So be the advocate, not just for the patient, but to change the way we do clinical trials. I think another way is to be prepared. We are definitely in the era of precision medicine. Sometimes you don't know if you're eligible for a study because you don't know if the genetic mutation is present. So when there is no pressure and there is no rush, and if appropriate, go ahead and perform that germline or somatic testing. Now we know specifically to prostate cancer, it's important to know whether there is a deleterious germline or somatic homologous recombination repair gene. And we know that basically means a problem in the DNA repair pathway, that there are now 2 agents, both PARP inhibitors, that are approved by the FDA. If you don't know the status, you won't be able to prescribe. And you certainly won't be able to enroll in a study. For bladder cancer, the same goes for fibroblast growth factor receptors. So FGFRs can be inhibited by a drug that's already FDA approved, as erdafitinib is, but you won't know that if you don't check. So one of the things that can be done to help facilitate enrollment in trial and or just to increase the treatment options for the patient is to know the status of their germline or somatic tests. And then to also be aware. Be aware and understand that, gosh, the accrual is already bad just in general for clinical trials, but it's actually worse for those who are in the disproportionately affected population. And that just means that we do not a great job in any day, but when it comes to those who are really at risk, we do a worse job. So we must recognize that the health disparity exists in all of our communities, and they come in different shapes and forms, and that it's important for us to understand the resources so that we can actually increase these accruals to clinical trials. I'm going to step back a second and say, gosh, I wonder really what the definition is of health disparity. So I put it here for you. There's an official sort of stance, which is cancer health disparities are adverse differences between certain groups in cancer measures. And there's some there listed: incidence, prevalence, morbidity, mortality, survivorship and quality of life, and burden of cancer or related health conditions. It's really important to recognize that the concept of health disparity is really quite big, and that the population groups is also quite vast. Many of us equate disparity with just race and ethnicity, but it can also impact socioeconomic backgrounds, age, disability, gender and sexual identity, and education. And the list can continue on. But just being aware that this actually exists might make you a better provider to be able to figure out how to enroll more of this group to your clinical studies. So here's an example of what I mean when I say that there are disparities by socioeconomic status and medically underserved. People with lower socioeconomic status have disproportionately higher cancer death rates than those with higher socioeconomic status. Seems intuitive, but it's really real. Individuals from medically underserved populations are more likely to be diagnosed with late-stage diseases that might have been treated more effectively or cured if diagnosed earlier. So that is a cancer disparity example that I hope to never show again in the future, but here we are today in 2020. When you look at racial and ethnic groups, here are some of the staggering statistics. African Americans still have the highest mortality rate of any racial or ethnic group for all cancers combined. And for all cancers combined, the death rate is 25% higher for African Americans than for whites. And in the Native American population, cancer is the second leading cause of death for those who are Native Americans over the age of 45. 45. And Hispanics, Latinos have lower incidence and death rates for most common cancers, but are more likely to be diagnosed with advanced stages of disease. These examples are, they still are appalling to me, but here we are, they still exist in 2020. If I do a deeper dive and say, well, in the genitourinary cancer world, where does this take us? Look at prostate cancer. 20% of African American men will be diagnosed with prostate cancer during their lifetime. And African American men have the highest incidence rate for prostate cancer in the US and are more than twice as likely as white men to die of the disease. This is a fact that confronts me daily in my own practice here in Detroit. So I'm very mindful of this information. In kidney cancer, the incidence and mortality rates are 2 times as high in men as in women. And American Indians and Alaskan Natives have higher kidney cancer incidence and mortality rates than any other racial or ethnic groups. They also, the women, the American Indian and Alaskan Native women, are 40% more likely to have kidney and renal pelvis cancer than non-Hispanic white women. Being aware of these disparities in your own practice is really important, as it may help you understand the community you're serving, and also figure out perhaps the unmet needs when it comes to trials. But in terms of resources, where I think this is particularly helpful for your own practice, whether you're in academia, a hybrid practice, or private practice, it's really important to know that the National Cancer Institute is trying to help us all. They have a Geographic Management of Cancer Health Disparities program, or known as GMAP. So those of you on the call can figure out, based on where you live and where you practice, what region you fall into. Michigan is in region 4, and there are resources that are available to figure out your needs, mostly with communication and education. If you look at who is part of region 4, in addition to Michigan, you can see that it's mostly the neighboring states. There are lots of resources. You are aware of perhaps of research projects and some other resources that might be important for your cancer center or your private practice. Whatever it is that you need, it is a tool. And that there's also a national outreach network, or NON. And these exist to help enhance the NCI's cancer health disparity research efforts through local and regional culturally tailored education and outreach within the underserved communities. So it's really important to know whether the National Outreach Network has something for you in your nearby area, as improved education and outreach might help you explain clinical trials and therefore increase our ability to enroll these folks. For those of you who are more academic on this call, it's really important to know that there's lots of funding opportunities that really look at disparity on a basic and translational level. You can invest in your community members as early as high school for improving their awareness of STEM and supporting them earlier in their journey. But these opportunities exist today if you visit that website. If you look and say, well, let's really look now at even prostate cancer, these are the staggering statistics. So we talked about whether it's 3 to 5% or 2 to 3%. It's basically low numbers of patients enrolling in studies, and 4.4% of Michigan adults. For those who participate, and again, I emphasize for those who participate, which is already a small number of a small number, only 6.2% were African American. To be able to properly generalize the results so that we know it's effective, whether it's a drug or a technique or a surgery or a gadget or a widget or a device, it's really important to know that the community that you're serving, that the data holds there as well. If you look at specifically at prostate cancer in these phase 3 trials, and these are thousands of patients, you're basically looking at 2 to 5.8% of African American enrollment in phase 3 trials today. If you look at genomics, understanding on whether the patient has been blueprinted, only 12% of samples come from African Americans in the TCGA database. That means we just don't have enough data to know even just the biology of the cancer. If you look at molecular imaging studies, 11% of African American men enrolled in an imaging study. I mean, this is go get a PET scan. We still have a disparity even with that. So at our center, we have really taken this challenge very seriously, and Dr. Egley, who's a colleague of mine, has developed a multi-level intervention to really not just target patients, but also target the providers, because it's important to be able to change the culture on many levels, but to really get to the root of it, we have to have a very targeted approach so that we can improve our own selves to be able to increase our accrual. So it comes down to what can you do in addition to what we had talked about. And one of them is just to encourage and be aware of yourself and your colleagues to individuate your patient. You know, one patient, just based on how he or she looks, is not representative of some racial ethnic group. These are individual patients that you need to take the time to understand where they're coming from, and be able to teach patient-centered communication skills. And that takes some practice. And this is an opportunity to teach the next generation, your fellows, your residents, and others who are in training how to properly do this. Because if there's a sense of common in-group identity, which is something that we've learned that patients do identify with and providers do as well, we will have just improved communication and being able to actually enroll patients successfully. And also to increase your treatment standardization. Don't just write it off like, well, this person's never going to ... What you want to say is, it's another patient, it's another day, it's another opportunity. One of the things that I encourage all of you to consider today is to take an actual implicit bias test. And I really applaud the folks at Harvard who created Project Implicit. If you go on implicit.harvard.edu, you can see how many different types of biases there are, of which we know as health professionals exist. But when you take the test yourself, you will be able to improve your own ability to understand yourself so that you'll be a better physician, provider, healthcare expert for your patient in your community. So I know we talked about a lot of strategies to try to really increase accrual, especially to genitourinary cancer trials. But I think by being aware of the definition of what cancer health disparity really is, and leverage your resources so that you can enhance your education and tailor your community outreach and really communicate. Use your national, regional, and local resources. People are there who are experts to help you. You just need to be aware of that and understand your own implicit bias, as this will help you understand how to improve your own practice. And moving forward, to be able to really do this right, we all must continue discussion and collaborations with all the stakeholders. So it's just not patients and doctors anymore, but so many different groups of folks that are involved, including pharmaceutical companies, insurance, and funding agencies. But with that, all of us really collaborating and communicating, we will not be successful in establishing a new paradigm, which honestly just means we have to do better in increasing the trial accrual so that all patients are properly represented. Thank you so much for your time.